Thank you for coming to this early session after a very busy week for everyone. So today, my name's Teresa Girolamo. I'm a bariatric medical practitioner, and I have got my moderators with me. I've got Melissa Whiting, who's a dietitian from Townsville, from Northern Queensland Minimally Invasive Surgery. And I've got Leanne McNamara, who's a bariatric nurse from St George Obesity Surgery. So welcome to this session. I'm thrilled to be chairing it. I think it's a really relevant session to all of us. So prehabilitation of the patients before metabolic bariatric surgery. And so I think, you know, we've got a really interesting group of speakers. We've got 5 different disciplines being represented, plus we've got a real world case study, so the lived experience as well. So I think that really shows how important it is, and this is an integrated health session. I think also my sort of ethos has been that excellent post-op care needs to start pre-operatively with good preparation and education of our patients, and I think that's what this session will show. So welcome again, and I will get Melissa to introduce our first speaker.
Thank you, Teresa. I would like to welcome our first speaker, Jared Walkley. Jared Walkley is a clinical nurse specialist from Austin Health in Melbourne and Darebin Weight Loss Surgery. Jared is here to talk to us about some of the clinical tips to consider in optimising patients prior to bariatric surgery. Thank you, Jared.
Thanks, Melissa. My conflicts of interest, but I would like to acknowledge the Beverly Breese Austin Health Nursing Scholarship, which has supported my attendance here today before I start. So it's a hell of a topic, and I could speak well into a week about this, but I promised Teresa I wouldn't. So I'll keep this to really defining what we know as ERAS, what we know as prehab, and then redefine those concepts for our patient cohort. I'll talk about patient selection and then apply this in some case studies so we know how to build this into our practice and then explore some of those future directions that we all want. So I'm the bariatric surgery nurse coordinator at a large tertiary centre, so Austin Health down here in Melbourne, and we're a pretty big player in terms of metabolic bariatric surgery and government-funded healthcare in Australia. So we do around 15% of all the publicly funded operations for this type in Australia, and we're one of only 6 that do anything that is considered sort of high volume, and that's a loose definition of that, but anything more than around 50 procedures a year. So we contribute quite significantly. We have an established ERAS. It's been around since 2018, and it has been a team-designed but nurse-led and nurse-managed model of care. Our patients are, compared to the Australian average, bigger, older, sicker, high rates of diabetes, high rates of insulin-dependent diabetes, and I have 8 surgeons that work on a shared wait list. And by that I mean that one surgeon will consent the patient, another person can operate on them, and another person can do the follow-up. So, and I'm privileged in a way that they largely turn up and do what they're told. And I say that with a lot of respect and also acknowledge the privilege in that. But we are confident in our team and we're confident in our processes, and so we allow that to occur. 85% of what we do is done at a secondary campus without prehabilitation, but 15% of our patients present as excessively high risk or high risk. So we need that risk mitigation, we need efficiency, but we have confidence in the process, as I said, and we have confidence in our team. So we have been able to demonstrate effectiveness in this process. So ERAS is what we know, and I'm not sure if many of you have been to the sessions yesterday around this, but it's an evidence-based multifactorial approach to reduce surgical stress and blunt that perioperative inflammatory response and improve the post-operative recovery. It's usually implemented in the lead up to surgery, and for the most part it starts when the patient sees the surgeon and they're selected at that point, and delivered by a multidisciplinary team. And the focus is on an enhanced recovery, and I really want to make the difference between the enhanced recovery and being a fast-track pathway. It is the natural consequence we'll end up with a shortened length of stay because of the enhanced recovery, but that's not the main focus. And this is what a traditional ERAS protocol looks like. Pre-operative, the patient has an assessment and a workup with an MDT and some education, VLED, and maybe, depending on your centre, some prehabilitation. Then there's an intraoperative phase and a postoperative protocol delivered by a number of specialties. And these could be specialist individuals, but not necessarily a specialist team. But complete intervention, and by that I mean adherence 100% to every component of an ERAS pathway, is nearly impossible to achieve. When we look at prehabilitation, or prehab as I'll call it in this talk, it's a model that introduces components of rehabilitation prior to undergoing intensive medical intervention to optimise that function and improve tolerability of that intervention. And it was discussed very early, back in the 40s, around preparing soldiers for war. It often looks at either a single or double modality, and either exercise or nutrition interventions are commonly employed, but we know that multimodal intervention is more beneficial. And it fits into the continuum of care prior to other interventions such as ERAS. Now that night there isn't representative of the World War II soldiers that they were preparing, but prehabilitation really is beneficial in identifying risk factors, and we can intervene with nutritional, exercise physiology, psychological support and perioperative medicine for our patient group. And early education, as we've heard Teresa say, and preparation is really important. And what I want to do is reframe this. And I don't know if a lot of you remember this advert, and I probably do because I really like tacos. But in this, we had the option of either hard tacos or soft tacos, and this wonderful girl here suggested, why don't we just have both? And everyone celebrated, and that's what we need to do. And that's what we do at our hospital. So what I'm calling pre-RAS, and I did not put a lot of thought into that name, it was just kind of easy there. We have a lot of time between our referral and when an operation is selected by the patient and our surgeon. So we use that time to integrate what we consider prehabilitation. We risk screen at the point of referral. So our referral form is designed to identify those areas of risk so then we can intervene. And all of that intervention is usually done before the patient sees a surgeon, and it's done by the multidisciplinary team. So you can see what I mean by saying they just turn up and do what they're told because we've already done it for them. So we focus on early referral to manage modifiable risk. We have an MDT discussion. We prescribe exercise phys, adjuvant therapies and education prior to going through the standard ERAS protocol. And at the other end, we also push that out to maintain lifelong intervention. It's a team-owned, team-driven, and we celebrate team outcomes. And that team includes our patients. And the benefit of this is similar to those of ERAS, so we reduce that physiological stress from surgery. There's standardisation, which allows for pattern recognition. There is enhanced recovery and the natural consequences of decreasing theatre time, length of stay, enhancing clinical autonomy, clinician satisfaction, improved patient satisfaction, and it's viable in nearly all patient groups. And there is still the benefit of introducing some components, if not all. And the best part of it is it identifies those early who might be at risk of failure to thrive. And the best way to describe this is in this analogy, which is not my own. So if everyone looks around the room and try and find the person that has a broken foot. You can actually look around, everyone. Try and find it. I've planted someone out there, okay? But no one could see that. But if I set off the fire alarm and made you all run out that narrow door, we're going to really quickly find the person that needs intervention and needs assistance to be brought along with the rest of the group. And that's what we do with that. So in terms of patient selection for this process, we've done a lot of the work for you, and I've given permission for my slides to be available, so feel free to adapt this to your centres. But we've published on this that this is a low-risk patient group, and I've talked about the secondary campus where we've got some reduced resources, which I'll go through, but this patient group, we select and safely proceed there and are a very low risk, a proven low risk. At that campus, we have no ICU or HDU backup. We have no option for after-hours return to theatre. It's a low acuity setting, it's 1.5 k's away, and I can't convert to miles, I'm sorry. There's no on-site dietitian and there is no on-site unit. Our unit is at the home 1.5 k's away. So we rely on our processes to just deliver that care. We consider this a low-risk patient group and traditionally probably wouldn't benefit from prehabilitation. SOBR's done the work for the high-risk patient group. And what we do with this is we investigate what can be modifiable, because prehab knows no value without modifiable risk. We look at whether a patient has severe OSA that is untreated and take them from a high risk to a low risk by treating it. We look at significant functional impairment, someone who might be wheelchair bound due to living with obesity and the impacts of that disease on their body, and take them to limited mobility and reduce that risk again. Control diabetes, control hypertension, metabolic syndrome, we make that stable as best we can, and we risk mitigate other factors. And as I said, prehab knows no value without modifiable risk, and that's the real take home I want you to have today. And in this patient group, we consider the use of what we classify as prehabilitation. And we consider this and whether this will bring benefit within a reasonable time frame. Is it worth delaying the time to surgery to intervene to reduce risk? Or is surgery the best option? And that's where a multidisciplinary team is really important to help work through those questions. And how we apply this is represented in a couple of these case studies. So we've got 2 patients that have both been referred for primary surgery. First one presenting as an excessively high risk, an Edmonton stage 4, whose weight was precluding life-saving renal transplantation. Had a number of comorbidities that placed him as an excessively high risk. And what you see in blue, it's a little hard to see, so hopefully when you look at the slides, all of what is in blue is done before surgical consultation. We referred to respiratory to get his OSA treated. We improved his nutrition state. We helped make his diabetes stable, and we balanced the risk assessment, and prehab was facilitated in a way that allowed him to have his bariatric surgery, lose 50 kilos, and be waitlisted for his renal transplant. So in this type of prehab outcome, we took an excessively high risk, identified early, modifiable risk factors, and took him from an excessively high risk to a high risk and facilitated life-saving treatment. And again, with the second patient here, she presented as a high risk in Edmonton 3, and there was a lot of presumptions made around her health. It was presumed she had heart disease, but we couldn't assess that because her body habitus precluded a standard echo. So what we did is we did a TOE, a transesophageal echo under GA, and balanced that risk, and we determined that the presumed heart risk was non-existent, so no one needed to worry about that. We treated her OSA, we took her from being wheelchair bound to be able to have limited mobility and move around, and her metabolic disease was stable. So she was high risk, and we've taken her to a low to moderate risk, and again has proceeded to surgery pretty sure yesterday. So the real take home from this is that this model, this pre-RAS model, really should be adopted for all patients and all centres that are providing metabolic bariatric surgery. It's safe, effective, all patients can do it, and prehab is an attitude, it's a team approach, and not just something on a piece of paper, and that integration for progress is key. Use your pre-RAS to form your high-performing team. And when we talk about those future directions, we've pushed the boundaries of what is considered ERAS to create pre-RAS, and we want to go even further. So prehabilitation, the future of prehabilitation starts in primary care. Preparation in primary care, education in primary care, risk mitigation in primary care, hopefully some funding in primary care, and then lifelong intervention. We cannot be operating and sending patients out into the ether. It should start in primary care and be a lifelong intervention. And the analogy is Alex's, so thank you very much.
Good morning. I'd like to introduce you to Dr. Ido Arts, surgeon from the Netherlands, bariatric surgeon from the Netherlands, who's going to talk about fact or fiction. Does correcting nutritional deficiencies prior to metabolic surgery, bariatric metabolic surgery, result in better post-op patient outcomes? He won't be available, I don't believe, for questions afterwards because he has a flight to catch home.
Yeah, unfortunately. And
Thank you, Ido.
Yes.
Oh.
Assholes. Again. My God.
We can...
Then we'll shift to the next speaker, and I'll do it afterwards.
Yeah.
And Alex, I'm still alive, my friend. You didn't kill me. See you after the next speaker. Is that okay?
Yeah,
and I'll
that's
give it to
fine.
him. Yes?
Perfect.
Okay, well, on that note, I would like to welcome our next speaker. Our next speaker is Dr. Simon Morris, a clinical psychologist from Geelong in Victoria. And Dr. Morris will be looking at some of the clinical tips on how we engage and retain our patients in the prehabilitation process. Thank you, Simon.
Clicker.
Thank you, everybody. It's all right. Good morning. Thank you, everybody. Try not my beard touch this, it tends to feed back. So, is that echoing? It sounds like it's me.
It's okay.
No, it's okay. I'll just leave it at that, so yeah, it's no problem. It's fantastic to meet everybody. So this morning I'm going to be talking about this prehabilitation process, primarily I think in contrast, which is lovely, perhaps I work primarily in the private sector where prehab is voluntary a lot of the time, and so this is a difficult, perhaps many of you out in the wilderness are working with patients where there's a degree of choice in that. So engaging them and retaining them is a huge issue. So I have no conflicts of interest.
There it is.
Thank you. So this should be really easy, shouldn't it? In theory, this should be very easy. We meet the patient, we assess them, we are working them up for surgery, we meet them and we shake their hands and they say, thank you, doctor, thank you, nurse, thank you, psychologist, dietitian. This absolutely sounds fantastic, and then they sign on, and before we know it, they've entered this fantastic prehab, whole program that we've designed for them. And yet probably in reality, we have more like this, where suddenly a patient develops the lightning speed that they haven't had, and they come running away from our room screaming. And I think we know there's some very familiar things that they tell us. I hear, I can't afford it, I haven't got time, I can't take more time off work. That would mean, I'm already looking after my kids. This has just got to work. I'm just relying on this working. And so what we come up with is, in fact, what we know is there's real barriers, isn't there, to people entering the prehab process, which is the whole reason why we're here to talk this morning. So to give us some structure to this, me not being the most structured person around, just a really recent publication looked at compiling a whole lot of reasons that are barriers and facilitators to people entering the prehab process. And they broke it down to these different capacities: psychological, physical opportunity, and social opportunity. And so what we saw was there was some barriers. And this is not going to be the focus of my talk today, but in fact there were some barriers, and we can see things that make sense. So patients, if they don't know what the benefits are, actually kind of having access to it, finding time to do it, lack of social support. And they found that there were facilitators of facilitate people in the prehab process. And this is prehab across the board, I should say, not prehab specific to bariatrics. But surely there's some lessons for us to learn. So things that just make sense, and the things that I'll be focusing on this morning, is things like the basic knowledge of the benefits of prehab. It makes sense, doesn't it? Like, they need to know what potentially we're offering to them. And also for us to think about encouragement by family and friends is found to be very predictive of people entering the prehab process, and encouragement by health professionals, and most certainly that is 100% our responsibility, isn't it? So those are the factors that I've highlighted and circled that I'll be kind of covering this morning. So could I have a brief show of hands who was here on Tuesday that saw my presentation? Yeah, thank you. So it's most of the room, which means I'll spare you going into detail. This was a model I presented on Tuesday. It was the idea that the demands of bariatric surgery are intense, and the patients that struggle the most are the ones where their own individual capacity to meet those demands are in deficit. So all the things that we're going to ask them to do, and this was the basic idea I talked about on Tuesday, is that bariatric surgery is demanding. And here was my very psychologist hack version of just thinking about what are all the things at the most basic level that we're asking our patients to do. And of course, when we look at them all together, and I forgot the most important one, which was mentioned out, to be drink water. I forgot to put on there too, which should sound simple, but of course it's incredibly difficult. So you put it all together, and all of a sudden the demands on our patients seem incredible. And so we start to, in this way I was talking about, we evaluate this very simplified model I presented. We think, wow, your capacity is so limited, we think prehab would be fantastic for you. And because we know there are possible outcomes. If they don't have the capacity they're going to need, sure, they might lose weight, but probably we think this is the group of people that will be progressive weight regain, that there'll be suboptimal weight loss, that they just can't meet everything that's been thrown at them, all the resources they've put in and we've put in them, they're not going to meet the kind of loss that we'd hope that they would get, that their demands are, they initially can meet the demands of bariatric surgery, so this is during the honeymoon phase. They do all the things, but of course we talk about doing all those things forever, but I think patients kind of have this idea, do it for now, almost like a diet, until the point that I don't like a diet, whereas of course we're talking about forever. But we're asking them to keep up these demands forever. And their capacity reduces over time, so this could be due to age, it could be due to other stresses in their life. Their ability to continue to do it reduces over time. And so what we say to them is that you're not ready. In some version, our anxiety in our assessment, certainly I know in the private sector, the feedback after my psych assessment is this message, we're really concerned, we think you're not ready. There's all sorts of reasons why we think that you would benefit. This part of your capacity is lacking, we're really worried about this. And of course, what does the patient say to us when we say you're not ready? Again, they run away from us again. And so we've got a problem, isn't it? We've now even done a really thorough assessment on this patient. We're not psychic, but this is the game we work in. We kind of know the outcomes of what tends to happen here. We say to them, you're not ready in some version. We point out all the deficits, but again, they run away. And again, it's too hard, or there's this magic kind of wish, once they get there, it's all going to work well. What we want, of course, is this. This is what we think is going to happen. We say, oh, this is all the ways that you're not ready, and they say, thank you so much, and shake our hand. And the problem is that as health professionals, we're actually in the sales game. We forget that. We're selling prehab. We're selling the idea of prehab. And I don't know about you, but I didn't do 1 second in my entire training as a psychologist in selling, how to sell anything. And we're terrible. We think we sell prehab by pointing out deficit and getting anxious and like very valid reasons we point this out. But this, in fact, is not helpful. Because what we know in the psychology of selling is that is, in fact, probably the worst way to sell something to someone. So we need to get much smarter. We need to think about their reasons, not our reasons. So just in a very quick overview, the sales psychology has the idea that you need to consider your target market and sell your products and services to your target market themselves and consider their psyche. So this is the key point, thank you, that you need to appeal to their current wants and needs rather than trying to convince somebody that they need the product or service. Does that sound familiar? Yeah, that's what we do. And this is where we go wrong. And so we need to recognise that people buy based upon emotion more of the time rather than logic. So we come at them with logic, but in fact they're going to buy or not buy based on emotion. So let's think about this in practice. So Sophie is pursuing her desire for bariatric surgery, and she meets us as part of the assessment. We identify her unstable mental health, her PCOS, she's never been an exerciser, she's got 2 kids with disabilities, and we think, poor Sophie's up against it. The ability for her to maintain everything, the demands we're going to ask over time is really limited. So we think that she's a strong candidate for prehab. She really stands out, even though physically she might be stable, emotionally, psychologically, socially, she's really behind it. And we're concerned she's not going to meet those demands. But rather than instead of rationally trying to tell her all the reasons that we're concerned and she's not ready, what we're going to do is we're going to focus on what's her current needs and wants. And her need is to be an active mother to take care of her kids. That's where she's at. So we need to explore the emotions. What's it going to feel like to be an active mother with your kids? You know, what's that going to feel like for you? Not just for them, what's that going to feel like for you? How good's that going to feel to run with them? And we need to validate the importance of that need and the difference that that's going to make to her life. And encourage her. We want her to make steps right away, like today, not in 3 months, not in 6 months. You deserve that today, that feeling of running with your kids. I want within 2 weeks you to be able to start to make some first steps of that with your kids. And we can help you provide that now. Come and check out this gym. We can really help you make steps towards that in a really safe way. And we know you're not an exerciser. And we tell her a story of someone we know who's been through a similar process. Someone who did come on board, someone who was looking after kids and was able to really discover this part of themselves that they didn't know existed. So let's look at a different example. So Troy is also pursuing bariatric surgery. He's got very different reasons. So Troy is an ambitious young health professional, but his lack of meal planning, he travels a lot, his high levels of stress, his emotional eating, we're just really worried Troy's just not ready. So we think he's a strong candidate, but again, we think his neglect and his career ambitions are going to keep coming before his health. So with Troy, the cell, rather than focusing upon his lack of awareness, his lack of kind of psychological, knowledge of his own needs, we're going to focus upon success. So for Troy, it's all about being successful. And success for him is a big part of his brand, and successful bariatric surgery he's going to use and leverage that in his future negotiations. I'm a success story. So we identified that Troy's got a business mentor. And so we'd say to Troy, well, look, don't believe me, but could you take this pamphlet and have a chat to your business mentor about our prehab program and how, in fact, this could be an important part of starting that success story now. It's going to make you even more likely to be successful down the track. We might talk to him about visualization and how seeing himself walking confidently into situations, and how much he loves that idea. But educate him, that's going to take a long time. That's going to take years. So we need to start that visualization now. We need you to come and see our psychologist now so that you can start seeing that, and even before the weight comes off you, to start walking in, appealing to his current needs and wants. So my message is that patients engage and they're retained in the prehab process because of their current wants and needs, not because of our valid concerns. So it's not to dismiss our concerns, but to understand the cell is in their needs. So focus upon their current wants and needs and how prehab will start meeting that now. Thank you very much.
There you go. Take two. Dr. Ido Arts, do you want me to introduce you again?
You can, yeah.
Oh.
No, just kidding. I have a sort of deja vu moment. I don't know why. But first of all, can I have a round of applause for Josh, who actually was able to upload the presentation. Thank you, Josh. He's so shy, he doesn't want to look up, but okay. Good. This might be a deja vu for you guys as well, because some of the slides you might have already seen either in the roadshow that we did or in the last session, but there's new things in there as well. And unfortunately, indeed, I have to fly out afterwards. We're going to talk about... Oh, now! Oh,
Sorry, Ido. Come back. Take three.
Okay, well. We're going to see whether prehabilitation in terms of multivitamins is actually fact or it's fiction. And it's a hard question to ask. Because can you do any research ethically in not treating your patients when you know that they're deficient? Well, I can tell you the answer is probably no for most of us. Now, not going into much detail, you've seen this slide many times. This is my practice, and it's around 60-40, so 60% surgery and 40% non-surgical. So last year we treated around 2,000 patients. We do have a lot of AREBs. We call it AREBs, by the way. And we actually, no, this is what we call it. It doesn't matter. And actually, we do not use any opioids anymore. And that makes that we consider all our patients having OSAS, so we don't treat it in advance. And we just give them oxygen afterwards and kick the bed sometimes when they snore. Good. And it actually works pretty well. Going to the last slide of yesterday's presentation. So these are the conclusions. You really have to look at the preoperative status. No one will doubt you on that one. I said sleeve is serious surgery, but of course metabolic and bariatric surgery is serious surgery, especially in terms of micronutrients. There's a lot of absorption alternatives. We'll go through that very shortly. And you really have to go ask your patients for multivitamin compliance. I think that it is the #1 complication considered after and also before bariatric surgery. Now, can you actually improve preoperative lab values? There was nothing out there, nothing. So luckily, Dr. Johannes Sander was so willingly, because he has a great clinic in which he does around 1,200 patients, and he was willing to actually look at his data. This is what in general is found, of course. This is not really unknown data, let's say, but based on what was out there in literature, keep in mind these patients have a little bit more fatty tissue than you and I have on average, and that means that, for example, for fat-absorbable vitamins, they are often in the blank because of their very high requirements. We came up with a formula and just started testing. So what we did actually was starting the impact trial, in which we included 120 patients. It's very simple. Blood check 1, give it for 3 months, look at compliance, check another time, and then afterwards go for surgery. Now, what we found was not really surprising, because we also asked patients to stop all their other supplements. So there were, of course, patients on vitamin B12 and iron, because that's relatively common in the premenopausal phase of patients with obesity. So that's where the negatives on the left side are and the positives on the right side. These are serum levels, right? So the vitamin B12 and ferritin obviously were down a bit. Copper was quite okay. Vitamin A and CRP actually were the right way. These were the ones that actually increased by using it. And of course, these are the happy ones. Let's say there was a lot of folic acid in it, also looking at compliance. And we made this to make sure that we had the least amount of hair loss. Because there are 3 things you have to consider in looking at hair loss. So you have the very biotin thingies that's never been proven. But there's actually a couple of factors. That is folic acid, it's ferritin, and it's zinc. Those are the 3 things that you have to look in terms of hair loss after surgery. So not clinically relevant, these. And this is actually what happened. So we had a halving of the amount of patients with a vitamin D deficiency. Same for iron. Very low number of folic acid depletion. But of course, with high vitamin Bs comes non-compliance in a couple of patients. Hence, the increase in the amount of patients with a vitamin A deficiency, for example. None of the patient after 3 months got a hypervitaminosis. So it was effective in improving serum values, decreasing deficiencies, and it seemed in these 120 patients relatively safe. Okay. Now, what is happening actually in bariatric surgery nowadays? What is happening is that when we consider bariatric surgery, age becomes an important factor, because we normally would focus, yes, I'm a guy, so I know 85% of us our patients are female, but I'm a guy, so put in a guy slide. We focus on the 18 to 65 years old, and actually now with the new ASMBS and IFSO guidelines, honored to write that with a couple of colleagues coming from Australia as well, we actually extend to the lower age limits, in which of course now the GLP-1s play a factor as well, but especially this one. You can ask anybody. You don't have to be a dietitian to know that elderly people are on average more prone for, let's say, a lot of things, including deficiencies. So if you are looking at age and wanted to choose a sort of surgery, it says, well, no longer is there an upper age limit, but you really have to look at comorbidities and frailty, especially the latter. I can tell you, you don't want to have truly frail patients on your OR. Now let's take another look at that hair loss. So hair loss has actually been researched pretty well. So this is a systematic review out of, when is it, 3 or 4 years or so. And it showed that if you look at the amount of hair loss, so a couple of the studies actually had the patients wear hair nets and count their hairs. Does anybody actually know why the most hair loss only starts 3 months after the surgery? Yeah, I see. Okay, so if a hair root dies, it takes 3 months before it comes loose, right? So the most traumatic is the surgery itself. You have a drop in your blood pressure, and that means that just anesthesia in any way will give you hair loss 3 months later, right? What helps is zinc, because zinc makes zinc oxygen complexes in your hair roots, and that makes that when you have very low oxygen levels, it can hold on a little bit longer. So, to prevent hair loss, short surgery, so not an hour, 24 minutes, that helps a lot, and you can make the zinc complexes that prevent it as well. You can have less hair loss in up to 50%. Very nice study that has been done. 2 times 1,000 patients. The one actually getting 21 milligrams of zinc 2 weeks, and the other not, and it saved the females 50%. So risk factors in these studies are again, of course, what we expected. Zinc, ferritin, and folic acid, those are the 3 that you really have to look for. Even if zinc levels are normal, or if they're in the lower range, you can thus supplement with 21 milligrams of zinc. I do that with all my patients, so it's something we do as a standard. Now, considering, let's say, fat-absorbable vitamins, on the left, that is, well, not me because it's a female, but as slim as that one. And on the right is one of our patients. And normally I always say I'm only interested in the fat around the organs and in the neck, but in this case not, because fat-absorbable vitamins go everywhere. So if you would be able to pour, let's say, the fat amount into a measuring cup, on the left it's, let's say, this, on the right that, and if you want to supplement, it's relatively easy to explain how to, because if you would pour in the same amount of vitamin D in the left cup compared to the right cup, I mean, you know that from drinks, right? Your kids would prefer the left one. But again, you have to use a massive amount of vitamin D to supplement your patients. So this is the formula that I developed and use. Quite often I know that a couple of our colleagues over here use them quite frequently as well. So what you do is the factor is 40, and 75 is the level you want to have in the blood, between 50 and 100. So if you want to go for 100, you have to use 100. And then you deduct what you measured and multiply it by body weight. You get the loading dose. That's on average around 300,000 units that you have to give. I actually stopped using the formula because I just give 300,000 units in any patient with a deficiency. Makes it much easier for the patient. The first and second week on Monday and Friday, 50,000 units, and then the rest in the 11 weeks to come. That works pretty fine. Then you stop again, and 6 months after, you just remeasure. And only 15% of your patients need an additional dose because they have lost a lot of fat mass, so that means that they need less vitamin D. If this goes too much into detail, then write me an email. Okay, there's one more issue that has been playing, especially in the US and in Australia, and that's because of, let's say, the fear of getting sued. It's thiamine. To be quite honest, thiamine is not an issue because if patients just take their regular dose of multivitamins, they are fine. But what is the big problem? If you have, let's say, an increased acidity, then it is not an issue. But what do you do after bariatric surgery? You give those patients PPIs, right? And PPIs actually break down, or actually the higher pH levels break thiamine down. These kind of food sources, so raw fish, tea, coffee, if you have those, terrible, it breaks down thiamine. But this is the number one, of course, let's say the functioning alcoholics amongst us, by the way, and our patients. Not saying I'm one of them. But in practice, there's a couple of things that you should just look at. It's a clinical symptom thing, right? So you can prep your patients by giving high doses of thiamine. You can do that, that's fine. It doesn't do any harm, so that's a choice you can make. But actually, I'd rather have you look at the clinical issues that patients might have. They got surgery. If they are nauseous all the time, they don't eat, they don't take their mollies. If they vomit, it's even worse. If they use PPIs, whenever they use more than 5 units of alcohol. If they have any sort of kidney disease, that makes thiamine break down quite often. If they're on the toilet like crazy often, of course, ask about their multivitamins, but it's especially us. We're just incredibly lazy because we don't want to look. A thiamine deficiency, in my opinion, is a patient that is not reaching out or a clinician being lazy. Good. One more. What you can correct preoperatively can be very hard postoperatively. You can, in this case, this is iron, give a patient an IV, that's fine, it works. But if you can do it pre-op with an oral supplement, I prefer that. But okay, opinions can differ. What you see here is on the left, the preoperative uptake after having given 70 milligrams of elementary iron in the bloodstream. If you calculate the surface underneath, you can actually calculate what percentage of iron is absorbed from the small intestine. We did that in the same 12 patients postoperatively, and if you lie them over, yeah, I'm almost finished. Almost finished.
I was going to ring the bell.
Oh, okay, well, do it. I'll wait for you. Okay, there we go. Thank you. So it depends on the form that you are actually giving. So this is actually gluconate. You see that the surface is amongst the same. But if you supplement with fumarate, preoperatively, it doesn't matter, same as gluconate. But if you look at it postoperatively, it becomes a hassle. So what you can achieve preoperatively sometimes is different than postoperatively. Now going back to the conclusions, almost there. So it's the same as I already said. And is it fact or fiction? Well, a little bit is fact in terms of zinc. You can supplement some things a little bit easier beforehand, but most of it is fiction, and it will never be proven because ethically you are not going to do any studies on it. So this is a hard one. We know from healthy patients that on average they're doing better if these micronutrients are up there. So just treat, and I don't even want to discuss whether ever this is going to be truly 100% fact. Now, thank you so much for having me. I hope I didn't bore you with all the 7 talks I had in the last 3 to 4 days. The Congress and knowledge is fine, but keep in mind that for some of us, especially me, it's about friendship. So first of all, I would like to thank the organization. In the room is Alex, of course, who did a great job. Thank you so much, Alex. And perhaps you might have seen this. I'm a huge Fatboy Slim fan, and actually here in Melbourne, one of his most famous concerts has been played in that open theater. Whenever you're in the Netherlands, do come by. If you want to see true fast-track surgery, we don't do any enhanced shit. No, just kidding. We do it as well. But do come and watch. Some of you have already been there. I know that 2 of you are coming in the upcoming months. We'd like to take you. You just go everywhere on the OR, etc. It's totally different than what you know, but don't think that you can take everything away. I wasn't allowed to take Jared with me. But again, no, that's it. Oh yeah, sure. Hope to see you all in Venice next year. And whenever there's questions, again, my name is either use my private edoarts@hotmail or arts@weightworks.nl to reach out. Many of you already do. Really like the questions. Thank you.
Thank you, Leanne.
Have you got time for 1 or 2 questions?
No. Oh yeah, of course. But I want to take a pic with all of you. Put your hands together. There you go. Excellent. Thank you.
Does anyone have any questions for Ido before he leaves?
Wow, it was that clear. Yeah, I know. Thanks.
Thank you so much.
Oh,
and
you have
for
one.
being here.
Good.
Oh.
Yes, just shout out loud.
Sorry, I was just wondering, when are you supplementing with zinc?
Yeah.
What happens with your copper? Is it okay?
Oh, good question. Good. That's what I love about Australia. There's so many people actually having good knowledge. New Zealand. Oh my God. I knew there were only 13 of you here, but okay, New Zealand. Yeah. Australian diet is terrible, don't know anything. New Zealand, that's where you should go. No, just kidding. It's a 1-to-4 ratio normally. If you give it for 2 weeks, it's not an issue. If you take it over, what you saw in the study, you saw copper, let's say, even increase in 3 months using that dose. So apparently it takes longer. So at least if you take it 3 months, it's safe. We didn't have any copper deficiencies.
And sorry, is your zinc supplementation pre-surgery or
Yeah.
from surgery for 2 weeks?
No, it's pre-surgery because the big issue is the anesthesia, the drop down. So you have to take it before. Yeah. Okay.
Actually, Ido, I've got another quick question.
Oh, okay.
You mentioned iron and ferritin levels. Do
Right.
you aim for certain ferritin preoperatively, particularly given a lot of our patients are female and men are ager, and do you like to sort of get them to a higher level in preparation for what might happen post-surgery?
So there's of course 3 phases in becoming anemic. So the first one that you can measure is the ferritin drop, and really do look at your CRP levels as well, because they mask sometimes terribly. It's officially not iron, but iron saturation which is next, and then only comes anemia. So if you're able to draw a line through the first step, so the lower ferritin, yeah, that's a good thing. So I'd rather go up to a 50. So I think that we supplement 1 in 3 of our patients. So it's relatively, and you don't have to give that much, and do give it, especially before surgery, every other day, because it's then absorbed better, right? So your liver doesn't actually block the uptake. If you give more than 30, sorry, this is going way too much into detail. If you give more than 30 milligrams of iron, for the 24 hours afterwards, all iron uptake will be blocked. So you actually get in more if you would divide it into every other day dose. But it's hard for our patients. Keep in mind, it's the 1 week, it's Monday, Wednesday, Friday, Sunday, and then they have to shift to Tuesday. That is, even for me, already hard. Okay.
Thank you. Thank you very much.
I'd like to introduce our next speaker, Kia Naylor. She's an exercise physiologist from Belgravia Leisure and Health Group in South Australia. Her topic today is, does increased structured pre-operative physical activity result in improved post-metabolic bariatric surgery outcomes? Thank you, Kia.
Thank you. Good morning, everyone. Just before I commence, I just wanted to pay my respects to the traditional owners on the lands that we are meeting on today. Just declaring no conflict of interest. It's an absolute pleasure. I've just gone one too fast. It's an absolute pleasure to stand here before you today, especially amongst some really, really cool presentations so far. Well done to all the speakers. I've really enjoyed them. I love that these presentations are designed to be short and to the point. That makes sure that we get to the heart of the matter really quickly. And I've gone straight to it. And the answer is yes. So does increased structured preoperative physical activity result in improved post-MBS outcomes? Yes, absolutely it does. But as health professionals, we need to ask 2 key questions: how and why? And these are absolutely critical when guiding our MBS patients through their journey. Let's start with the why. The research strongly supports the role of structured physical activity in prehabilitation for MBS patients. The benefits are absolutely clear: improved surgical outcomes, faster recovery, fewer complications, and better long-term health management. But let's break down a few key findings for you. Pre-surgical weight loss. Studies show that combining physical activity with dietary interventions leads to significant weight loss before surgery. This reduces operative times and lowers the risk of complications. Improved mobility and recovery. Patients who engage in pre-surgical physical activity have better post-operative mobility, shorter hospital stays, and quicker returns to quality of life. Cardiovascular and pulmonary benefits. Aerobic conditioning improves health and reduces the risk of anaesthesia-related complications. Reduced post-operative complications. Regular exercise before surgery has been linked to fewer infections, blood clots, and respiratory issues. Better metabolic control and improved mental health benefits. Preoperative physical activity can be shown to reduce anxiety, improve the mental well-being, and is absolutely crucial for the long-term success after surgery. But of course, there are still challenges in the research, and that is particularly around adherence and customisation. We heard Simon talk really well around some of the challenges and barriers to prehabilitation programs, and a lot of them are existing health issues and low motivation. Furthermore, individual programs are absolutely critical, as each patient's journey is unique and often requires adjustments for other comorbidities and physical considerations. So let's now shift to the how. And this is absolutely the most important part of today's discussion and my talk. You can have the best research and theory in the world, But if you can't connect with and empower your patient, adherence and their overall health outcomes will be affected and negatively. We as health professionals play a pivotal role in our patients' healthcare journey. But we must acknowledge that they're often referred to us during some of their most challenging times in their lives. It's our responsibility to create a supportive and caring environment that helps them reach their goals in a way that works best for them and sets them up for surgery success. This is where person-centred, outcome-driven care comes into it. This is not new, this has been around for a little while, but this approach is the absolute cornerstone of high-quality healthcare and is especially important from a physical activity and exercise physiology perspective. It's about respecting the preferences, the needs, the values of each patient. Customisation isn't just a challenge that's been identified by the researchers. It's the reality of clinical practice. No two journeys are the same. So we must adapt our physical activity prescriptions to suit each patient's unique goals, needs, and barriers. It is really important that we ask our patients the right questions to support them meaningfully and ensure that they are heard. Questions like, what comes to mind when you think about physical activity? Are you excited? Are you intimidated? Are you scared? And where do you feel most comfortable being active? How can I best support you? What can we do to make movement easier for you? These questions will help build trust. Once that relationship is established, we can then create the most effective program for them. While the research suggests the combination of resistance and aerobic exercise is ideal, adherence is what drives outcomes. Often patients are more comfortable exercising at their home because, let's face it, gyms can be really intimidating. And our goal isn't to go from 0 to 100. It's to take incremental steps forward from 0 to 1 to 2 to 3 and so on. This is about creating a sustainable routine, or as we like to call it, active well-being. Even the language that we use can make a really big difference in this space. Fitness can feel intimidating, so if you do take one thing from today, let's just scrap the word fitness and focus on movement instead. Part of the component of how we can influence and support the outcomes in this area is the transition of care. If you are in a clinical or multi-D team supporting the prehab of the client, this is absolutely fantastic. The approach is set up for success. But importantly, we also need to look at the options that are going to work for the patient to meet their goals. Maybe they are visiting from a regional town or a suburb that's too far away to commute to regularly. Our role in working together with the local providers is key. It should be about what's best for the patient. Leave your ego at the door. Cross-refer when required. There is no more power representation of person-centred care than when allied health refer to allied health. This isn't a competition. This is somebody's life. If and when the time is right, setting up that care pathway and those relationships that help the patient feel comfortable is key. Examples might be, if you're able, go with the patient to the new service provider, so there is a constant for them. They have a relationship with you already. They help build that bridge to the new service provider. Create a relationship with the provider so that they can come and visit the patient in your clinic setting. Clear communication and a great handover. Maybe you want to look at creating video walkthroughs or something like that of the new environment. I know in all of our facilities we have visual stories that are available to help break down those barriers. Information like the smells, the sights, the sounds, all of that can help a patient feel more comfortable. When we put the patient at the centre of their healthcare, we have a critical role to play to support them in any transition of care. So to wrap up, I'd like to touch on a project that we're currently working on within Belgravia, within our Partners in Health program. We operate hundreds of community-focused leisure facilities across Australia and New Zealand, and we have a really strong exercise physiology and health program with 40+ team members and growing. But we're very cognizant of the fact that our venues can be really intimidating places. And with this in mind, we're developing a program that supports patients from the comfort of their own homes using app technology and telehealth support. The opportunities in this from a prehabilitation perspective are endless, and as they progress, and if the time is right, we will help transition them into a supportive, inclusive community environment at a place that suits them best. Because we also know that loneliness and social well-being is just as important as physical and psychological well-being. We're co-designing this with patients who have lived experience, ensuring their voices shape the program, and a key feature is the use of Surge, an app that allows patients to alert our teams before they arrive, letting us know how we can best support them. This ensures that our team can tailor their approach and create an environment that feels safe and welcoming. And if you haven't heard of Surge, I strongly recommend you go on their website and have a look at how Surge might be able to be used for you. Okay, so to summarise everything for you. 1, adjust your approach to be person-centred and outcome-driven if it's not already. 2, implement development within your team and colleagues to ask the right questions at the right time. And 3, the only way that we can make change to the wider community is together. And remember, any movement is good movement. And a cheeky plug at the end, we've just launched our socials, so there's a QR code there, and if you want to get in touch, please feel free to email me or visit any of our websites across the thing. So thank you very much. It's not rocket science, it's absolutely about putting the patient at the centre.
Thank you, Kia. I think I can speak for all of us. It's really lovely to have exercise physiology join the discussion in treating our patients. So it is a pleasure to introduce our next speaker, Liz Goodall, a bariatric dietitian from Auckland City Hospital in New Zealand. And Liz will talk to us on how we can optimise diet quality and eating behaviours in patients prior to bariatric surgery. Thank you, Liz.
Thank you, and welcome everyone. And just building on a comment from Simon, today I'm hoping to sell you my ideas. So here goes. How many times does a client come into your consult and say, I have tried every diet under the sun to lose weight. I lose the weight, I put it back on. Now I just want a solution to let me lose weight, keep it off. Sound familiar? Yeah. We also know from many of the presentations that we've heard this week that success is far more than a number on the scales. So success is a lot of things, but one of the things it also is getting people out of that diet mentality. Also remember that loss of control eating is a really common issue that our bariatric population experience. The good news is that there is a model that we can consider to help address diet mentality, getting out of that strong diet thought, help address disordered eating, and along the way ensuring nutritional safety and enabling eating in a whole range of different environments. Kind of sounds like the golden cure, right? So my suggestion may perhaps surprise you, but then make a whole lot of sense. So the RAVES model is a model initially developed by an Australian psychologist, Shane Jeffrey, for the management of classical eating disorders, so anorexia nervosa. But on examination, it is very relevant for our bariatric cohort as well. So RAVES model, it consists of 5 progression steps, each building on the previous steps. So regularity, adequacy, variety, eating socially, and spontaneity. So first up, regularity. What are some important things that we know about the importance of regular eating? So first of all, studies have shown that skipping breakfast correlates with less weight loss. We also know that eating late in the evening correlates with less weight loss. And there's studies that show that weight loss maintainers are more likely to have 3 meals a day than people with weight recurrence. So, and additionally, some eating behaviours associated with weight recurrence after bariatric surgery include loss of control eating as well. And we know that regular meals helps to reduce the incidence of binge eating episodes. Also looking at shift workers, so this is another area where perhaps regularity is more difficult. We know that the disrupted circadian rhythm in these shift workers can also contribute to weight gain. So when you're looking at these workers, is what is the best pattern that we can develop for these workers? It might be different if they're working day shift, night shift, on days that they're not working. I find it really useful to have that concept of an anchor meal. So perhaps 1 or 2 meals a day that stay the same and basing the other meals around this. So when do you see these people and their eating habit is just erratic because I've never sat down and thought it through? So before surgery, this is something that we can do to work out these routines and these habits with eating. A lot of this also comes down to being prepared as well. So we've also heard presentations in this conference about ADHD and the struggles that perhaps those patients have. It's all well and good to say, yes, have 3 meals a day and have these meals at like 8 o'clock, 12 o'clock, 6 o'clock. But how can we help people do that? So some things like double batching a meal so you've got leftovers for the next day, having meal kits, doing online shopping, putting meals in the freezer, having what I call emergency meals. So on those days where you don't have anything to eat, you've got something that you can just grab quickly. So maybe your emergency meal is a can of tuna, a tin of tomato pasta sauce, some frozen mixed vegetables and some pasta. And you've got a meal that's perhaps not the previous default of takeaways that person might have led to. And the last comment in regularity and the importance of regularity is medication. So if someone comes to you and their medication adherence is not very good, how good is their multivitamin adherence going to be after surgery? So it's thinking again like strategies to help that person. And perhaps for some people, it might be useful to start taking their multivitamin before surgery so they can get into that habit. Setting alarms, blister packs are other things that can be useful this way. But it's just talking with every person to what are the strategies we can put in place to help them have regular meals. Next up, adequacy. So adequacy in my mind is really about nutritional safety. And I look at our cohort of patients, so I work in a public hospital, the health literacy in a lot of our patients is not as high and perhaps in private practice. So things like macronutrients, protein, carbohydrate, fat, how can you expect someone to meet their protein requirements after bariatric surgery if they don't even know what the protein foods are? So a lot of my work is talking about, well, these are the protein foods. If you're going to have breakfast, what will you have for breakfast? Oh, I'll have Vegemite on toast. Okay, well, how can you put protein with that? So just working with them so they know what the protein foods are. Micronutrients, so Ido's talked about that, so I'm not going to talk about that in detail, and I don't have enough time. But fluid, if someone's one of those people who swig back a whole lot of fluid at once, they're not going to be able to do that after surgery. So if they're in that habit of sipping water really frequently before surgery, that's a really good step that you can also take to prepare them. And special consideration, so if someone is very active and they've perhaps got more requirements, or they work in a very physical job, and of course maintaining strength is important for everyone, but for those people, it's maybe even more important for them. Or they work in a very hot environment at work, what are some of the things that we can do to meet their requirements then? So next up is variety. So variety is giving permission to people to eat everything. So if it's someone's birthday, you can have a piece of birthday cake and eat it and not feel guilty about it. And sometimes you see people who come into your clinic and they're very structured. They've got no sugar, no fat, and they're very, very controlled with their diet. And it's trying to move away from that so they're able to eat food in a more varied environment. So having no forbidden foods, we know that as soon as you restrict a food, that's the biggest predictor for binging. But I think, moreover, in this situation, people often come to a dietitian and they've got negative conceptions about a dietitian. Perhaps they've seen a dietitian before, they think dietitian equals food police. Like, we know that that's not the case. But as soon as you're giving people permission to have a piece of cake and talk about your reasons for it as well, then you can see the relief wash over their face. And it's part of that rapport building, which is really important for them to come back and see you after surgery as well. And remember, one of my key phrases that I often use is that they're not cheat foods, they're treat foods. So eating socially. So I work with a lot of people with Māori and Pacifica backgrounds, and as in a lot of cultures, celebrating around food is really important for them. So how are they going to be able to manage those eating situations after surgery? You go to an event, it's disrespectful to not have food. So I remember talking to one lady, and she was a social worker. She travelled around a lot of different houses, and in every house she was offered food. It was rude of her to turn it down, and we talked about different strategies on how she could manage it. And in the end, she agreed that she'd accept the food from the person. She wouldn't eat it there. She'd take it away with them, because then she'd still be accepting their food, and then she'd give it to the next household. Which is, there's also food insecurity in the population she was working with, which I thought was quite a good strategy. Eating out as well. Like, how are you going to be able to manage that after surgery? Are you just going to be open and tell people that you've had bariatric surgery and then perhaps are accepting of what you do or you don't eat? Or are you going to go to a tapas restaurant or a restaurant with shared food in the middle of the table that you can share from? Or are you going to have entrees? So it's just thinking about different strategies on how you can manage this. It's also, if you're at a large event, how are you going to be able to manage it if people are trying to put food on your plate all the time? Are you going to walk around with a full plate of food so no one can put more food on? Are you going to be more involved in the kitchen and preparing food so you're busy or talking with children so you're busy and so you're not having that pressure to eat? Are you going to put a napkin over your food when you finish? Are you going to take it with you? Are you going to offload it to your husband? So there's a range of different strategies, and it's just talking with people and being that really patient-centred approach to work out what works best for each person. Alcohol, again, so we recommend no alcohol in the first 9 months after surgery. It's a little bit like having a baby. But it's just, what are going to be your strategies if you've used alcohol as a coping mechanism or alcohol in certain situations? How are you going to manage that if you're in a situation where everyone's drinking and you're not drinking at that situation? And it's the same kind of thing for work eating as well. So then we're getting to spontaneity. So this is also called the diet nirvana. So this is kind of getting to the stage where you're not even thinking about what you're eating. It's just natural for you. You're able to eat a variety of foods. You're not having to worry about whether you get enough protein or not. You're not having to worry about whether you can have that treat food or not. It's just part of your normal eating. And I'm going to leave it there. Everyone's different. Everyone's journey to bariatric surgery is different. And I think putting in the RAVES model is a really nice model that you can use, and people can slot in it wherever they need to along the way. Thank you.
I'm going to introduce myself. So my name's Leanne McNamara, and I'm going to just change the pace a little. We're going to go back into patient level a little bit now because I'm going to introduce my lived experience with one of my colleagues who I'll introduce shortly. Find my slides. Nope. We did check this first, and it did work, so. Yeah, there's a couple of slides before that, though. That's it. Thank you. Thank you. So this is our patient. Katie's a patient of ours from our clinic at St George Obesity Centre. Katie was really happy to share her story with you all today, to get her voice out to a group of health professionals. She gave valid consent for us to do that, both written and verbal. Katie had overwhelming social anxiety before attending her first appointment with our clinic face-to-face with our team. She'd not left her home for 6 months. She presented in a wheelchair with her parents in attendance, and still states to this day that her biggest fear about coming into our clinic was the fact that she was going to be the biggest patient coming into a bariatric centre. This is a really interesting case, and there's a lot to unpack with this case. But today it's all about prehab. So this is Katie's story. Katie had a little bit of medical history. She's a 28-year-old female. She had a total thyroidectomy in 2018. She's now on replacement therapy. She presented to us in January 23, and you can see her weight and her measurements there. This is just a little bit of pathology, which I don't think will be too surprising to anybody in the room. It's not too out of the ordinary. A little bit of social history for Katie. She is of Samoan descent. And of course, that leads to the issues of traditional diet versus Western diet. She's the eldest of 8 siblings, and she lives at home with both parents. Katie was a second-year nursing student until she grew out of that position, sadly. So I'd like to show you, we have a short video that we've put together for Katie on her in regards to her prehab time in hospital. I'm going to present to you now Cassandra Octaviano. Can I get it right? She's our nursing unit manager from the hospital at St George Private Centre of Excellence in Bariatrics. After Katie's video, Cassie will come up and talk about the prehab program. Thank you. I'll play the video first. This is Katie's story.
So, hi Katie, this is the day of your surgery today. Yeah. How are you feeling? It's been a bit of a journey to get here.
Yeah. I'm excited, nervous, but really excited.
Yeah. What are you excited for?
Just a new start to a healthier, lifestyle.
Yeah. Good.
Getting fit.
Yeah.
Changing my, just this new journey that I'm going to start.
Yeah. So how's your journey been so far? How have you found it in hospital?
At first it was a bit hard to get used to, but as the days went by, I started getting into my little routine of my diet and my physio. So that's been helpful.
I think
my mind off.
Yeah. Well, I think one of the big things I've noticed since watching you is that just your mobility's improved so much.
Yeah, I can't believe when I first came here, I was like wheelchair.
Yeah.
And now I'm able to, walk around.
Yeah. Can you remember what your weight was when you first came in?
I think it was roughly around 261.
Yeah. Yeah. And by coming into hospital and managing it in hospital, you've got down to 240. Well done. And not in a wheelchair anymore.
No, I'm able to walk around and by myself too.
So what was your routine like at home that made it easier to come to hospital and do the pre-op in hospital?
I think just with at home, I guess I didn't have I think with the nurses here helping me, I had accountability and, being able to focus on, what I had to do, and also I had an actual routine going. But at home, I'll normally wake up almost lunchtime because my sleeping was very off, and I mainly, just slept in the early hours. But at home it was difficult because, temptation and everyone's eating everything that I like.
So do you think you'll be able to manage when you get home?
Yeah, definitely. With what I've learned here over the past, being here for a few days, definitely got to keep my routine that I've been doing here and just making healthier food choices. Yeah.
And what sort of work are you going to do when you go back to work?
Well, I'm hoping to go back to finishing my studies.
Yeah.
And
Nursing degree?
Yeah, finally finish my nursing degree and maybe one day I'll work here, who knows?
Excellent, that's what we want.
Yeah.
All right, well, all the best today, Katie, and we'll see you on the other side, okay?
Yeah.
What were your thoughts leading up to the last few days before surgery?
Before the surgery, I was doing well. But I think as it got closer to my surgery day, I was, still nervous, scared. I think it's because I've been thinking about this and waiting for so long that it's like finally here, and I'm finally going to go through with it. So, but yeah, I was excited too. Because I knew that it will definitely change my life.
Yeah. Kate, I just want to go back to and reiterate on something that I think we should discuss as well. You were introduced to Mounjaro on the ward, and how do you think that that medication helped you in that prehabilitation process?
Mounjaro helped because it helped to suppress my eatings. I didn't really feel like I had to eat a lot throughout the day, so that did help, and also it just helped bring the weight down too. So
Yes, good. Okay. Yeah. Excellent. And how are you feeling now?
Feeling great.
So we're 4 months post surgery now. It's been a long journey. It's been over a year. We've been working with you, but we finally got you to surgery in December last year. So it's been 4 months. And you're 55, nearly 55 kilos down. Mobility is a big thing, and it's increased a lot, hasn't it?
Like I can definitely feel like a change in the way I eat, also the way I view like foods. I know like to choose healthy options, not the unhealthy options, but also my mobility too is a big thing. Because for the surgery, I wasn't really moving around and leaving home, but now I'm able to do that.
Excellent.
So the surgery's not a lot.
And if you had the chance, would you do it again this way?
Yes, definitely.
Would you change anything?
No, I wouldn't change a thing. I think this process has definitely helped me with preparing just for life after surgery. And just preparing me to know like what I'll be doing and expecting myself to do. So this process has helped me out.
Right.
Thank you for that lovely video, Leanne. So I have no conflicts of interest to disclose. What an amazing story. The team at St George Private and I were so happy to assist Katie with her prehabilitation. We focused on promoting healthy behaviours by prescribing exercise, nutrition and empowering Katie with education. The prehabilitation focused on physical and mental aspects of the surgery, as well as decreasing the pre-surgical risk and optimising Katie's functional capacity. When Katie first came in, she was 262 kilos. After 4 weeks of prehabilitation, she was down to 240 kilos and was offered bariatric surgery, a gastric sleeve. Before Katie admitted to the ward, we discussed with Dr. Cheng and the team the patient's goals of care, as we generally don't admit patients for prehabilitation, so this was new for us. We gained support from our executive team and began to organise the appropriate beds and equipment for Katie, including a commode, a bed, a lifter, and ensuring there was enough space for Katie and her family. Our initial board-based assessments and care included vitals, bloods, continuing drug therapy, skin integrity, making sure that Katie was practicing good hygiene, as well as a falls risk assessment. As you saw in the video, Katie was in a wheelchair when she first came to us, making her a high falls risk. It was obvious that she was quite breathless and there was a lot of effort when transferring from bed to chair when she first came in. The next step was involving the allied health team. Our specialist dietitian put Katie on a very low calorie diet, including Optifast, steamed vegetables and a portion of meat a day. Our physio put Katie on a program which initially started with sit to stand, light resistance training, walking around Katie's room to begin with, and then eventually laps around the ward, around the hospital, and then eventually the hospital gym. During the first part of Katie's admission, she preferred to walk around late in the evening as there were less people around. Prior to Katie's admission, she was housebound, and this was due to her social anxiety surrounding her weight. Katie was studying a Bachelor of Nursing, as you saw in the video, and dropped out during the pandemic. During the pandemic, she was at home assisting her family with 8 siblings and continued to put on more weight and became disconnected from the rest of the world. We knew it was a big decision for Katie to have this surgery, and the nursing staff really focused on promoting routine and accountability, with regular check-ins from the NUM, the assistant NUM, as well as utilising our patient care boards, encouraging good sleep hygiene. As you saw in the video, Katie had an issue with sleeping till midday on most days at home. From a psychosocial point of view, we focused on Katie's anxiety. At the beginning, Katie struggled with being out of home and being in an unfamiliar environment. We tried to encourage Katie's family to come and visit as much as possible, offering flexible visiting hours, encouraging her family to bring in things from home like pillows and blankets and books. Katie has a Samoan background, and we were able to meet her cultural needs by creating space for her family to come and visit, helping facilitate religious practices, as well as providing education to Katie and her family about their diet, as well as not bringing in food or eating in front of Katie during visits. Katie had a family reunion occur during her admission. With a lot of thought, Katie decided not to go, as she thought it would be really difficult to maintain her weight loss goals at her family event. Katie stayed focused during her admission, and she was determined to have the surgery as she knew she really needed it. Using a multimodal aspect of prehabilitation, we found the physical and mental. Katie was physically and mentally ready for her surgery. She was now 240 kilos. Post-operatively, Katie recovered well and was handed over back to Dr. Cheng's team. Katie plans on returning to her studies and hopes that one day she'll become an RN and work on the same ward she did her prehabilitation. This is a photo of some of our lovely team, and thank you for listening to Katie's story.